Hello, you beautiful people. I am a medicine resident and I'm super excited to share my handwritten notes with you all, which I have learned from Harrison and other standard books. So, today, let's have a discussion on one of the important topics of respiratory system, asthma, and learn it step by step. So, let's get started. So, starting from the definition, what is asthma? It is an episodic airway obstruction and hyperresponsiveness along with airway inflammation. It is eosinophilic and most of the time reversible. The symptoms include episodic shortness of breath, wheeze, cough, chest tightness, mucus production, more commonly seen in boys as compared to girls in the ratio of 2 is to 1. In blacks, it is seen to have a greater mortality and morbidity as compared to Caucasians. The fact that there is increased mortality associated with the beta 2 agonist use and the steroids causes decrease in mortality. Before starting this page, I want to tell you that these boxes I have borrowed from Harrison. And let's start. The exposure and the risk factors related to the development of asthma. The allergen exposure in those with predisposition to atopy, occupational exposure, airway pollution, infections including viral and mycoplasma, tobacco, obesity, diet, fungi and allergic airway mycosis, acute irritants and reactive airway dysfunction syndrome, high intensity exercise in elite athletes. The genetic susceptibility, risk genes, and atopy, along with the exposure and the risk factors seen above, causes symptomatic or asymptomatic asthma, which includes airway hyperresponsiveness with or without inflammation and structural changes. So, there is increased symptoms or exacerbation with increased airway hyperresponsiveness, increased inflammation, and structural changes. The triggers that we will see next, along with the unknown factors, causes recurrent exacerbations. The triggers of the airway narrowing are the allergens, irritants, viral infections, exercise and cold, dry air, air pollution, drugs, occupational exposures, hormonal changes, and pregnancy. The most important hallmark of asthma is the airway hyperresponsiveness, which is actually a acute narrowing response of airways in reaction to the agents that do not elicit airway responses in a non affected individual, or there is excess narrowing response to the inhaled agent as compared to a non affected individual. So, in this diagram, you can see there is a normal airway and there is a airway hyperresponsiveness, which is causing vascular proliferation, there is neuronal proliferation, there is cellular infiltration, there is excess of mucus production, airway edema, invagination of airway mucosa due to smooth muscle constriction. There is also epithelial denudation and shedding. Now, what causes airway hyperresponsiveness? So, there are three stimulus, like first is the direct smooth muscle acting agents, which are the histamine and methacholine. Then there is the stimulation of sensory nerve, which is causing smooth muscle or inflammatory cells to contract and causes smooth muscle constriction. There are also release of inflammatory cells, which causes release of bronchoconstrictors and mediators, causing airway edema and mucus secretions. So the airway thickening is directly proportional to the disease severity and duration. Now this airway thickening causes smooth muscle hypertrophy and hyperplasia, subepithelial collagen deposition, airway edema, and mucosal inflammation. The severe kind of asthma causes neutrophilic inflammatory cells to be released. There is a thickening of subepithelial basement membrane, which is because of the deposition of collagen, tenascin, periostin, fibronectin, and osteopontin. So I have made a diagram showing there is a hyperresponsiveness due to proliferation of the epithelial cells, and which is in turn causing airway narrowing. There is something which is called a strophic unit. The strophic unit is nothing but there is a separation of the columnar cells from the basal cells. Now, the strophic unit causes multiple growth factors release and causing airway remodeling, release of multiple cytokines and mediators, in turn causing airway inflammation. Now there is also angiogenesis which is seen, which is due to in turn due to airway inflammation. There is also excess of mucus production, which in turn causes decrease in the luminal area. So the neuronal proliferation which we have seen in the diagram causes release of neurotropins, which is actually elaborated by the smooth muscle cells, epithelial cells, and inflammatory cells. This neuronal input regulates the smooth muscle tone and mucus production, which in turn causes an increase in the airway tone and acute bronchospasm. Now, this asthma has been divided into atopic and a non-atopic one. So, in children, it is the atopic one which is causing the asthma, and there is also increase in Ig levels. In non-atopic individuals, it is mostly seen in adults, and it is eosinophilic. So, the inflammation part of the asthma, there is the type 2 inflammation which is seen, and this is the CD4 T helper cells which are causing the inflammation. So there is this interleukin 4, 5, 13 playing a role. So this interleukin 4 causes production of Ig, and this Ig binds to the mast cells and basophils. Now this in turn causes environmental sensitivity to allergen, and as a result there is a cross-linking of Ig on the surface of these mast cells and basophils. This causes release of cytokines and activators of smooth muscle constriction and causing edema. The interleukin 5 controls the formation, recruitment, and survival of the eosinophils. Interleukin 13 causing airway hyperresponsiveness, mucus hypersecretion, and goblet cells metaplasia. So this was all about the allergic stimulus. What about the non-allergic one? So the non-allergic stimuli causes production of type 2 cytokines. This type 2 innate lymphoid cell causes production of interleukin 5 and 13. And this type 2 innate lymphoid cell is actually activated by epithelial cytokines, which causes the alarmins to release, which is produced in response to a non-allergic epithelial exposure, such as irritants, pollutants, oxidative agents, fungi, and viruses. This is a non-allergic stimuli and can be associated with eosinophilia. A severe asthma, it is actually a non-type 2 inflammatory process. It is not responding to steroid, and it is neutrophilic inflammation. May be associated with a chronic infection, that is one of them is atypical pathogen, that is mycoplasma. Now let's study the mediators. The first is the cytokines. So as we have already seen, there is a type 2 inflammation which is in turn causing interleukin 4, 5 and 13 to be released. There is also something called as thymic stromal lymphopoietin, and the other interleukin, that is 25, 33 and 9. The non-type 2 inflammation includes release of interleukin 6, 8, 17, tumor necrosis factor alpha, and interleukin 1 beta. The second is the fatty acid mediators. So there is a release of arachidonic acid, which in turn is divided into leukotrienes and prostaglandins. Now there are two types of leukotrienes. This is the cysternine leukotrienes, and we have the non-cysternine leukotrienes. For the cysternine leukotrienes, we have C4, D4 and E4, which are produced by the eosinophils and the mast cells. Now what is the role of this cysternine leukotrienes? It is a potent smooth muscle constrictor. It stimulates the mucus secretions, recruits the allergic inflammatory cells, cause microvascular leakage, modulates cytokine production, influence neural transmission. The non-cysternal leukotriene is the LTB4, which is produced from the neutrophils, macrophages, and epithelial cells. So again, there is this diagrammatic representation of whatever cytokines we have studied. The type 2 inflammation and the non-type 2 inflammation. The prostaglandins, that is the PGD2, has the CRTH2 receptors. Now, the prostaglandins are released from the mast cells. What are the CRTH2 receptors? It is nothing but chemoattractant receptor homologous molecule, which are present on the Th2 cells. The fatty acid mediators responsible for the resolution of the inflammation are the lipoxins and the resolvins. The third mediator is the nitric oxide. Now, this nitric oxide is a potent vasodilator. It increases the mucus production. It is a smooth muscle proliferator. It is produced by that of the epithelial cells. Okay. Now, this interleukin 13 is actually directing the epithelial cell to produce the nitric oxide. And along with interleukin 13, the eosinophils, mast cells, and neutrophils also direct the epithelial cells to produce the nitric oxide. The fourth is the reactive oxygen species, causing the smooth muscle contraction, increase in mucus production, airway hyperresponsiveness, epithelial shedding. There are certain chemokines, so let's name them. Eotaxin, TARC, MDC, that is macrophage derived chemokine, which attract the Th2 cells. Rantis, that is nothing but CCL5, which is a pluripotent prophlogistic effect. Now, the heritable predisposition. So, 25 to 80% of them have the heritable predisposition. So, there are certain genes, that is ADAM33, DPP10, ORMDL3, TSLP, interleukin 12, interleukin 33, HLA-DQB1, HLA-DQB2, TLR1, TL6R. What is atopy? Atopy is a genetic tendency which is causing specific Ig production in response to allergen. The exposure and the risk factors. So we have already studied in that table, just elaborating few of them. These are the allergen exposure, the tobacco, if the patient is a ANC and she's a smoker, which will cause asthma in a child. Air pollution, causing oxidative injury to airways, producing airway inflammation. The infections such as mycoplasma. Occupational exposure. Now, this occupational exposure is divided into immunologic stimulus and a irritative stimulus. Talking about immunologic stimulus, we have high molecular weight and we have a low molecular weight. If it is a high molecular weight, including proteins and flour, and low molecular weight, we have formaldehyde and diisocyanate. In diet, one of the deficiency, that is vitamin D, and it is also seen the maternal supplementation of zinc, vitamin C and E decreases the asthma in children. Maternal polyunsaturated fatty acid supplementation decreases the childhood asthma. Increased maternal sugar intake causes increase in asthma in child. Obesity associated with adipokines and interleukin 6. Medications such as H2 blocker and proton pump inhibitor increases the risk. Maternal conditions such as preeclampsia, prematurity, or neonatal jaundice or LSCS in the neonates. Now, reactive airway dysfunction syndrome. It is nothing but a bronchial hyperactivity and bronchospasm. The causative agent being oxidizing and reducing agent and a high level of a particulate. The pathology includes epithelial injury along with the neutrophilia. It differs from occupational asthma. These patients have not become sensitized to a provocative agent and can return to work once they have recovered. So this is occupational asthma. But the reactive airway dysfunction syndrome these patients, they have become sensitized to the provocative agent. Infections like fungi and mycosis. So most commonly we have the Aspergillus fumigatus causing allergic bronchopulmonary aspergillosis, which is causing type 2 airway inflammatory response, wherein the Ig levels are more than 1000 international unit per ml, eosinophils being more than 500, and a positive skin test. It is seen that 2/3 of the patient grow aspergillus in sputum, and so adding an antifungal is necessary. Now, the triggers of the airway narrowing, these are the allergens, the hormonal changes in pregnancy, perimenopausal, or premenstrual, irritants, viral infections, neutrophilic or eosinophilic. Now, this Ig levels, which are increased in the asthma, causes a decrease in the interferon, and in turn, it causes increase in the infection. Now, the exercise, the drugs, which including beta blockers, aspirin, occupational exposure, air pollution. How does exercise cause increase in asthma? So, exercise causes dryness in the airway lining and changing the tonicity of the lining cells, causes release of bronchoconstrictor mediators. And cold air is associated with airway edema. What about the comorbidities? So, this table signifies the comorbidities that may make asthma difficult to control. So, differential diagnosis of disease with overlapping symptoms that can present with obstructive pulmonary function test. One of it being the heart failure, chronic obstructive pulmonary disease, alpha 1 antitrypsin deficiency, airway obstruction from mass or foreign body, inducible laryngeal dysfunction, bronchiolitis obliterans, bronchiectasis, tracheobronchomalacia. Comorbidities that can make asthma difficult to control: chronic rhinosinusitis or polyposis, obesity, gastroesophageal reflux disease, inducible laryngeal dysfunction, COPD, anxiety or depression, obstructive sleep apnea. So, there is this rhinosinusitis, which is actually a eosinophilic inflammation causing inflammation and irritants, irritates the airway lining, causing release of secretions in the lower airway, production of inflammatory mediators and cells. So, the treatment is with intranasal corticosteroids. The vocal cord dysfunction causes inappropriate narrowing of the larynx, producing resistance to the airflow, more commonly in women and with anxiety and depression. So, the laryngoscopy can be used during symptomatic episodes or during obstruction. Now, how to approach a asthmatic patient? So, there will be a recurrent wheeze history, there will be shortness of breath, there will be chest tightness, there will be cough, and of course, it runs in family. So, how to differentiate between a cardiac dyspnea and asthma? So, the dyspnea in asthma is slow to rise after exercise and slow to resolve. If there is any acute exacerbation, then we should note that there is tachypnea. The saturation level will fall less than below 90%. There will be tachycardia. There will be sweating. There will be use of accessory muscles. Patient speaks in words. Pulses paradoxus. And PEFR will be less than 60%. The pulmonary function test says the reversibility would be more than equal to 12% increase in FEV1. At least there will be more than equal to 200 ml at least 15 minutes after beta 2 agonist administration. The diurnal peak flow variability would be more than 20%. Methacholine challenge says that there will be decrease in FeV1 by 20%. Mannitol can be used to access the airway hyperresponsiveness, being an hyperosmotic agent. A challenge with a cold or a dry air, that will be a positive response, that is more than equal to more than 10% drop in FeV1. Eosinophilic counts. It would be more than 300 cells. It correlates with the severity of the disease. Their presence in patients with severe asthma indicates patients will respond to medication targeted at type 2 inflammation. Fraction of exhaled NO. It is an approximate indicator of eosinophilic inflammation, which is suppressed by that of inhaled corticosteroids. So, more than 20 to 25 ppb causes severe asthma, and there is a need to use moderate to high dose of inhaled corticosteroids in these patients. So, this was for today. We will study the treatment part in next video. Keep on watching.